Welcome back. Thank you, Kim, for your patience. Thank you, everyone, for your patience. Before we get started, so today we're going to focus on space medicine, emerging challenges, design constraints. Are you able to see my screen? No, it's not shared yet. Okay, let's try this.
Oh.
Now you should in 3, 2, 1.
Yep, it's
Perfect.
coming.
Perfect. Any questions from last time from exponential thinking, engineering the future, thinking about trends and technologies in medicine? Anything on that before we get started here? No, okay, seeing none. All right, so let's get started. So today, as I talked about, we are going to discuss space medicine, what we know so far and what the challenges on the horizons are, and how you may play a role in all of this. So I promised you would get more into my exploration and extreme environment background this talk. So we saw a glimpse of the slide from last time. So in addition to teaching in this class, working as a general practitioner and doing rural emergency medicine, I wear a hat as an explorer, an aquanaut, and director of the Space Medicine Group with the International Institute for Astronautical Sciences, as well as one of their scientist astronaut candidates. So that means we get to do all manner of bioastronautics testing in space-like environments. We're going to talk about what that means a little bit later this lecture. But this is kind of a snapshot overview, and I think we shared the slide last time. Lots of different affiliations. I don't need to go over this again because the relevant parts of it will come out as we get into this talk. So what do I want you to get out of this? My hope is by the end of this talk, you will have a sense of the hazards of the spaceflight environment, how we prepare for space, what design constraints we face, how we prepare for space in on Earth, emerging technologies, because this is a technology in the future of medicine course that may help us for future space travel, and emerging challenges that come along with us. If there's questions as we go along, feel free to put them in the chat. I'll try to pause 3 to 5 minutes early so we can get to questions and discussion. So let's start with a question. So imagine you are the physician on a lunar mission today. What do you pack with you to become prepared for this lunar mission? And so when we look at how we survive an environment, if we go back to first principles, some of you might be familiar with Maslow's hierarchy of needs, which starts with survival, then goes to safety, and then escalates from there. But if we're being realistic, we probably need some connectivity too, this being 2023. Joking aside, to know how we pack for austere environments, we need to be familiar with the challenges that come with that environment. So when we talk about space and space flight, this includes a huge laundry list of hazards, everything from the being able to survive the increased radiation load in space, which we'll talk about more in detail in a few slides, the acceleration, deceleration loads of launch and landing. So those are increased depending on the flight profile and the vehicle that you take, altered day-night cycles. So when you are on the International Space Station, your rate of orbit is such that you experience one sunset-sunrise cycle per 90 minutes. So that's 16 sunrise-sunset cycles per 24-hour period. It's a very stressful, confined, highly operational environment. The ISS schedule is scheduled down to the 5-minute mark. So you have to be able to deal with that stress, those pressures, be a good teammate. You don't want to be the astronaut that's voted off the spaceship. There's the risks of what you do. So when you're on a spacewalk, you might be faced with the risk of a decompression sickness. So for those of you who are divers, you may know that this is a real risk if you ascend too quickly from depth. Bubbles of nitrogen dissolved in your bloodstream can come out too quickly and then lodge in bad places. And so when you're an astronaut going on a spacewalk, you're going from the higher pressure of the station to the lower pressure of your spacesuit, because if it's too high pressure, it limits your movement. So without the proper preparations and breathing oxygen ahead of time, you put yourself at risk for decompression sickness. If you do run into medical constraints, you're remote and resource limited. You have to trust the engineering of your spacecraft to protect you from the hazards of the spaceflight environment. So that's the vacuum of space. So there's no oxygen in space. You have to bring it with you. You have to trust the engineering of the spacecraft to protect you from orbital debris, micrometeors, anything that can impact your spacecraft. You have to trust the enclosed loop life support system, not just to provide an atmosphere, but to also continuously scrub it and maintain the temperature, humidity, and pressure within habitable confines. This includes trusting the scrubbers to cleanse the atmosphere of off-gassing from organic compounds. And then there's also the usual risks and lumps and bumps of things you might encounter on Earth, like burns, fractures, abrasions, the usual. And for those of you who are paying close attention, you might notice that we have so far skipped discussing the very obvious thing that we all think about when we think about the spaceflight environment, which is, of course, microgravity, or colloquially known as zero-G. And the summary of this is that simply every single bodily system is affected by the space flight environment. So if you were to throw out a bodily system, it would be affected by microgravity and space flight. So bones lose density at a rate of 1.5% per month, reflecting an osteoporotic state on Earth. If you don't introduce countermeasures, which we'll talk about a little bit later, your muscles lose mass, because again, every single one of us in this lecture is taking it for granted that our muscles and our bodies are doing work to keep us upright against 1G, whether we realize it or not. Without that luxury in 0G, bones and muscles don't have to work. So they get rid of that mass, they get rid of calcium leaches out. There's fluid shifts as well. So all of that fluid that typically pools in our feet in 1G shifts upwards. This has several consequences. So between the fluid shift and the increased calcium leaching from our bones, astronauts are more prone to kidney stones. So having a history of kidney stones is actually a disqualifier for spaceflight. The increased spaceflight load or fluid load can lead to the baroreceptors in our heart and our carotid arches to interpret this as having more fluid load, and some reports of increased urinary excretion for the first period of time on station. Astronauts will develop a puffy moon face appearance, which you can see here in Japanese astronaut, Dr. Chaki Mukai. So you can see here that in the 1G state, she has a typical facial appearance, and then in the 0G state, her face is puffy, it's rounded, it looks more full because of the fluid shift. And part of the consequence is that astronauts feel more congested, they feel like they have a cold all the time, so food will actually be more bland and less tasteful, and that food has to actually compensate for that when we think about sending food up to the station. We talk about the cardiovascular changes, we talked about that a little bit, but just to get into that in more detail, with this increased fluid shift, the heart becomes more spherical on station, and then when you return to this 1G state, all of that venous return pulls back to your feet. Your valves are decompensated, so astronauts are actually prone to orthostatic hypotension, or what we commonly known as fainting, once they return to the 1G condition. And so when you see astronauts being returned to Earth and being carried off the Soyuz capsule with a hero's welcome and those garlands, part of it's pomp and circumstance, but most of it's safety, so the astronauts don't faint and hurt themselves when they get back to Earth. And the list goes on and on. So we know immunologically the immune system is suppressed and germs are more virulent in the spaceflight environment. Luckily, that's not of clinical consequence. And then coming back to 0G adaptations, in the first up to 72 hours on station, there's this mismatch as our brains try to get used to this 0G environment. So what our eyes see versus what our proprioceptors are interpreting as our position in space versus what our inner ears are interpreting as up and down is at a total mismatch. And this can make astronauts extraordinarily sick, to the point of intractable nausea and vomiting, which, if you could imagine, you had to conduct a spacewalk during that, is inconvenient and actually hazardous to one's health. It poses an asphyxiation risk. So critical events like spacewalks are not planned for the first week on station. And that usually settles down. And your fun piece of trivia is that informally, this is called the Garn scale, named after one of the early, I think it was a Mercury astronaut, who later became a U.S. Senator, Jake Garn. He was so intractably ill. The more Garns you have on the Garn scale, the more like his unfortunate circumstance you are. And despite us having exposure to about 60 plus years of human spaceflight history now, the surprises keep coming. So in the past 15 years, the spaceflight associated neuroocular syndrome has been described. So when we talk about fluid shift, it's everything. This includes the cerebrospinal fluid, that proteinaceous brain juice that coats our brains and spines, tends to also not drain as it would in 1G. And this is not uniquely or not universally distributed. So there's actually local pockets of increased pressure, including around our optic nerves that exit our eyeballs and connect them to our brains. And so this can lead to increased pressure and swelling on the optic nerve, and in certain populations cause vision changes, which is a showstopper almost for long duration space flight, because the longer in space you are, in space flights over 30 days, is when we tend to see this more. And for reasons we actually don't know, tends to have a preponderance for male astronauts. So there are certain gender-based changes that we see in female and male astronauts. So SANS is one of them. In female astronauts, because of the shorter urethral distance, we see them more prone to bladder infections. Female astronauts are more prone to orthostatic intolerance once they get back to Earth. So they're more prone to fainting versus male astronauts, whereas male astronauts will tend to have cardiovascular changes on orbit that we see. And then, as I promised, to have a slide dedicated to dentistry as well as some links. So there's, like I said, every single bodily system is affected in space, and dentistry is one of those fields. It's ripe for further research because we're sending humans to space for longer and longer periods. So we need to know more about preventative as well as in situ care. And so we talked about calcium leaching out of our bones. This may translate to increased risk of caries or cavities in space. We talked about immunosuppression in space. This might lead to an increased risk of dental infections in space. The crew medical officer who's on the station, which we'll talk a bit more about this lecture, has to know how to pull a tooth, do dental extractions in case of tooth abscess in space. And there's pressure changes, there's increased G-forces, there's limited dental access to full-on dental care. So as we look towards longer mission profiles, say a 3 to 5 year journey to Mars, we need to know more about preventative as well as in situ care for dentistry. And so I've included a few links here just for further reading, but the bottom line is if you have an interest in a specific bodily system or area of human spaceflight, there's probably a role for study for it. And like I was saying, the field is continually evolving. So here's a snapshot that was published in Science in 2017, and this is the famous NASA twins study. And so basically there's two identical twin astronauts, Mark and Scott Kelly. Scott Kelly was up in space for approximately 1 year, his identical twin, and they're both Navy test pilots. They're both NASA astronauts. Mark was on Earth, and so they did the most comprehensive study of humans in space, looking at everything from the macro level, so performance, cognition, to the systems level. So they looked at gut health, they looked at immunological function, to the micro level. They looked at DNA methylation, they looked at proteomics, metabolomics. So it's a really interesting paper to read. In certain cases, there were effects that were transient. So, for example, the gut microbiome was different in space for Scott than it was for Mark, but these changes reversed after 6 months. In certain cases, Earth functioning was preserved. So Scott Kelly administered the first vaccine on station. As part of the study, he gave himself the flu shot, and the immune response was as expected. So he gave himself immunity. And then there were unexpected changes. So, for example, telomeres. Sorry, was there a question?
No.
Okay, so telomeres, which are associated with aging and which shorten over time, were found to lengthen in space. So there's still a lot of question marks as to what truly happens in space. What is adaptation? What is maladaptation? What we have to worry about and what we don't. Um, and like I said, this is the every time we send humans to space, there's more and more experiments going on. So in 2019, they were doing routine handheld imaging studies of the jugular veins on station using an ultrasound, handheld ultrasound. And they were just trying to look at blood flow. And lo and behold, in one of the astronauts, they saw a giant floating clot or venous thromboembolism. So now we have to ask ourselves, well, does being in the zero G environment, um, does that lend us to a hypercoagulable state? Does that lend us to being more prone to blood clots? One Canadian group last year found that we know that red blood cell mass is decreased during spaceflight. They furthered that study and found that there's increased red hemoglobin breakdown or hemolysis during spaceflight. And there's a pretty good overview that was recently published in the past month or so here that just gives a overview of human health during space travel. So I've included the link there. But suffice to say, if you remember nothing else from this introduction to human hazards in space, it's simply that space is trying to kill you. And this is what we know from decades of exposure and research from low Earth orbit. So then the question becomes, what happens when we go beyond low Earth orbit? And this isn't simply a theoretical question because the international community led by NASA, the Canadian Space Agency, the European Space Agency, and Japan have very real plans to go to the moon and beyond, starting with Lunar Gateway. So this is humanity's first deep space station beyond low Earth orbit. So unlike ISS, Gateway is not continuously crewed. It is going to be crewed for 3 months at a time. It'll have a smaller crew size of 3 to 6. It'll be smaller than ISS, and its goals are Earth observation, sun observation, lunar observation, astronomy, and then serving as a waypoint to the moon itself, paving the way for the Artemis missions, which is NASA's plan to put the first woman, first person of color, and next man on the moon in the later part of this decade, with a view towards, again, furthering exploration, testing out in situ resource utilization, testing out science, and excitingly, establishing permanent lunar surface operations by the end of this decade with Artemis 3, as well as serving as a test bed for Mars. And it's not just the public domain, it's not just governmental space agencies that are looking towards exploration class or deep space missions. Elon Musk and SpaceX have been announcing plans to send humans to Mars for quite some time. And then in 2016, when SpaceX announced that, Boeing said it would try to beat SpaceX for sending humans to Mars. So there's kind of a new space race in the private sector as well. So that begs the questions. We question that we already talked about. There's all these hazards that we know of from low Earth orbit. So how do those considerations evolve when we talk about deep space missions? And so the answer is lots. And so we know from the Apollo missions, limited though they were, that lunar dust posed a very real health risk to astronauts. It was this fine silicate-like dust that got everywhere. It caused skin and respiratory irritation. It clogged up the joints on spacesuits. So for anyone who tries to tell you that the moon landings were faked, keep in mind there's like hundreds or thousands of pages of accompanying documentation as to the biomedical and scientific effects and studies. So whoever faked the moon landing put a lot of effort into it. So in fact, because we are sending humans back to the moon, there's emerging studies. This was published in the past few weeks about an overview of lunar dust toxicity risk, including some of the exposure risks that we talked about. I promised you that we talk a little bit more about radiation. And the bottom line is higher up you go, and the further out you are, the more of a risk radiation becomes. And so when you are within the protective confines of Earth Van Allen belts at the level of the ISS, you're in low Earth orbit, you're at 400 kilometers, all the higher energy ionizing radiation from solar particle flares, from galactic cosmic rays, all that stuff is mostly filtered out. So you're still relatively protected at that height. And so this schematic from the European Space Agency illustrates it very well, that if you're considering yourself to have exposure to 1 unit of radiation when you're at, excuse me, at the ground level, you're exposed to about 40 times that amount on a traditional commercial airliner. And you're exposed to nearly a year's worth of radiation exposure at the level of the ISS in a single day. And so when you translate that risk to a Moon to Mars mission, that it changes to 700-fold what you would be exposed to on Earth. And then it's higher energy, so it's potentially more damaging. And then the duration of exposure is longer because with current technologies, a sojourn to the red planet is about 6 to 9 months, depending on the alignment of Earth and Mars. And we also know that there's system and organ differences. So certain systems are more prone and more sensitive to radiation changes. So blood forming organs, like the spleen, like bone marrow is more sensitive. Reproductive organs, especially in females, are more sensitive. So there's actually yearly limits based on this for exposure to radiation, and there's gender differences as well as lifetime limits. And so we can see already when we look at previous Mir mission, the 1 year limit was exceeded for blood forming organs by a little bit. So now, if that's still within the confines of low Earth orbit, think about how that's radiation protection limits and/or protection is going to need to change as we look to going to the moon, Mars, and beyond. The other challenge is the autonomy needed. So for those of you who are Hitchhiker's Guide to the Galaxy fans, you'll know that Douglas Adams quote that says space is big, so vastly, hugely, mind-bogglingly big, you wouldn't believe it. And that applies to travel to Mars. And so even traveling at the speed of light, depending on the alignment of the Earth and Mars, you are faced with a 6 to 46-minute round trip communication delay. So now if you are the crew doctor and you have a catastrophic event on Mars, or say your crew doctor is taken out, you don't have time to radio back to mission control on Earth for help. So then we also need to increase the autonomous diagnostic and treatment capabilities for crews on Mars. So when we talk about how we summarize the challenges and the framework for looking at health and exploration class emissions, we call this the RIDGE framework. So that stands for radiation, isolation, confinement, distance from Earth, altered gravity environments. So remember, we talked about 0G on ISS, 1G on Earth. It's actually 17% on the moon and 38% on Mars. And then everything else which falls under hostile environments. That includes the dust, the altered day-night cycles, the communication delay. And at the moon, by the way, a round trip communication is 2.4 seconds. So coming back to our initial question. So with all of this whole discussion started with a simple question. You are the crew doctor for a mission to the moon. What do you pack? And this started with saying, well, let's familiarize ourselves with the challenges we're facing. So that's one part of the puzzle, but not to stress you out, why don't we look at the tools we have at our disposal? How do we prepare our crews for space? So this starts with risk mitigation and prevention. So for those of you with an engineering background, you might recognize this as a traditional risk matrix. And when we look at risk matrices, we look at the likelihood of something happening versus the consequence if it does happen. So if something is high consequence, high likelihood to happen, it needs to be mitigated before the mission can proceed. Whereas if something's very low consequence, low impact, if low likelihood of it, if something happens, you probably don't need to worry about it. Part of this includes prevention. So government space agency astronauts are very rigorously selected. They're selected for physiology, psychology, physical exam, as well as their skill set. And so looking at previous NASA and CSA selections, being colorblind, having high blood pressure, having endocrine disorders like diabetes will screen you out. But even things like being anemia, even though that's reversible, has screened people out in the Canadian selection, having a history of herniated discs, walking around with kidney stones that don't cause you trouble because they may cause you trouble in spaceflight. That's also a cause for disqualification. This whole idea of risk mitigation and prevention continues with aggressive rehab, in-flight countermeasures, and post-flight rehab as well. So it's a little bit of prehab and rehab. So what I mean by that is astronauts are given personalized exercise for aerobic activity, as well as building up muscle on station to mitigate the bone and muscle mass loss that we talked about. Astronauts have to perform 2 hours of aerobic and resistive exercise 6 days of the week. And your fun bit of trivia is that the treadmill on station has a pretty fun name. So Stephen Colbert, the late night talk show host, is a huge space fan. He a while back, NASA, when it was introducing its newest ISS module, he had his fans overwhelm the voting system and vote to name the newest NASA module after him. And NASA said, well, we can't do that, but why don't we name a treadmill after you? So in famous space fashion, because everything's an acronym, the treadmill is called the Combined Load Bearing Ergonomic Resistance Trainer, which stands for Colbert. So that's where that name comes from. If you're wondering how we do a resistive exercise and weightlifting in space, it's actually based on a resistive hydraulic system. So you can still do squats and lifts in space using hydraulics. This continues with in-flight monitoring. So we know from monitoring, for example, that astronauts have sustained or have experienced cardiac arrhythmias, but luckily those are self-limiting and asymptomatic. It continues with nutrition. So we talked about nutrition needing to be more flavorful because of this fluid shift. It also needs to have more, needs to have high calorie value per unit weight because it's expensive to send things up to station. It needs to have a long shelf life. So an orange, for example, doesn't have a long shelf life and is relatively heavy compared to freeze-dried food. So it's actually not a good investment. It's considered a luxury that we would send up at Thanksgiving or Christmas time. It needs to be flavorful, it needs to be textured, and it also needs to make up for nutrient losses that we would see in the spaceflight environment. NASA also puts its astronauts in pre-flight quarantine. So NASA was doing it before COVID made it cool. We alluded to crew medical officer training. So there is no guaranteed physician on ISS at all times. It's actually a crew member who undergoes CMO training, 40 to 60 hours of standard medical procedures, everything from putting in an IV to pulling out a dental, an infected tooth or draining a dental abscess. And that person may or may not be a physician. And with that, there is an onboard medical kit, medication, procedures, and protocols adapted for zero-G. So we talked about a little bit about this with crew monitoring as well as prevention by screening. We talked about the exercise and countermeasures system. And then there's the onboard system that consists of treating pathologies in situ. So there's basic life support, advanced life support packs. There's airway support, management support kits that we'll take a look at in a few slides' time. The other tools, and this might interest the comp sci students in the class, is computer modeling tools. So before we get to that, the other thing I should mention is that the crews that support the healthcare teams that support astronauts are very, very multidisciplinary. So we've kind of alluded to them already. So we've talked about physiotherapists, occupational therapists, nutritionists, aerospace medicine trained flight surgeons, psychologists, and more. So it takes a crew to support the astronauts on station. So moving on now to the computer modeling tools we have at our disposal. So this is from the NASA Johnson Space Center's Exploration Medical Capability. This is the Integrated Medical Model, or IMM. And basically, it allows us to plan how much medical kit we'll need for a different mission profile based on what is already on the International Space Station. And so basically that is our starting point. This is what we have on station. And then we enter our different variables. How many crew are going? 3 people, 6 people, more? What is the duration of our mission? Is it 9 months? And then we look at the likelihood of incidence of various medical events. And then we input our tolerability limits for loss of mission, loss of crew. And then that gives us our kit contents. The one downside, if you're paying close attention, is, well, it's pretty one-dimensional, because what if we end up using the same antibiotic for a bladder infection, a skin infection, and a respiratory infection? Then you're going to use up that resource pretty quickly. So we need something a bit more dynamic, which is why the follow-up to this is called the Medical Extensible Dynamic Probability Risk Assessment Tool. It's called the MedPrep because that's really cumbersome to say. And this is based on neural networking and Bayesian modeling, and it allows us to account for repairs, adverse events, and countermeasures at various mission time points, allowing us to project different possible end states. So it's a lot more dynamic. So I alluded to this in the IMM slide, but what do we even plan for that could happen in space? So this is the XMC top 100 medical conditions. So it includes things that are mission ending and deleterious, life-threatening, so cardiac arrest, mass hemorrhage, to things that commonly happen in space, which luckily tends not to be the life-threatening stuff like skin abrasions, irritation, congestion headaches, CO2-induced headaches, because remember, in the zero-G environment, we don't have convection. So we breathe out CO2 when we sleep, pockets in front of our face, causes a headache. And then it's also the things that hopefully won't happen, but are equally terrifying, but not life-threatening, like diarrhea in space. We talked a little bit about dental conditions. So you'll see here there's a lot of attention paid to dental conditions, everything from pulpitis to exposed pulp, dental infections, abscesses, dental trauma, avulsions, tooth loss, cavities, loss of dental work, and then even simple toothache. So what happens in space? This is what could happen. Here's a snapshot of what has previously been documented on shuttle missions. So it's luckily, like I said, it's the annoying stuff, but not the life-threatening stuff. So we talked about the space adaptation syndrome, which happens in the first 24 to 72 hours, but then settles down. So it's annoying to be that sick in space, but it's not life-threatening. We mitigate that by not doing critical events like spacewalks. We've talked about abrasions, digestive issues. So you can't burp in space. Many end up with constipation, and then infections. So bladder infections, skin infections, respiratory infections. Not listed here, but as I previously mentioned, on previous early missions, we've noticed cardiac dysrhythmias like runs of ventricular tachycardia, which is terrifying if you're an emergency physician on Earth. But luckily, this tends to go away, and the astronauts tend not to notice in spaceflight. So the next piece of the puzzle, knowing that what we're planning for and what tools we have at our disposal is, how do we logistically and practically translate that into operations for spaceflight? How do we pack for space? For those of you who are avid hikers, campers, outdoors people, you may have heard of the backpacking principle, and that is simply that you can't bring it all with you. Everything that you bring with you is at the expense of something else because of limited mass carrying capabilities and limited volume. I like to call this the Aladdin principle of space because it's phenomenal cosmic power to get to space, itty bitty living space once you get there. So to translate that into our design constraints, and this may come up on the exam, hint, hint, is things have to be low cost, low volume, low power, easy to use. It has to be low astronaut time to train and to use, because remember, they're scheduled down to 5 minutes at a time. It has to have a long shelf life. It has to be hardy. So if something is very, very radiation sensitive, maybe it's not the best thing to bring on mission. And then we need to consider how human health is just one piece of the puzzle. How does that fit in with the engineering? How do we engineer the space station to be ergonomic and to minimize any compounding any health challenges? How do we optimize performance? And then how do we tie that into the mission parameters, objectives, while taking into environment, which we've talked about, and how does the spacecraft further support the mission? I promised you that we would take a look at how the design translates into reality. So remember, we talked about some of the life support packs, the first aid kits on station. So true to the design form is they're very compact, very lightweight. There's minimal waste. There is a dedicated medical kit for medications, dedicated kit for supplies like gauze, dedicated kits for vital signs monitoring, for respiratory support. There's a defibrillator on station. So as we get back to talking about exploration class missions, getting back to that ridge framework, when we talk about the challenges looking forward for long duration spaceflight, it expands that ridge framework again, looking at everything from dust exposure to bone loss to things that make sense but we don't typically think about. So skills performance and skills deterioration. Say you trained in a skill on Earth and then you don't have to practice it till you get to Mars 9 months later, you're going to be rusty. If you're the crew medical officer and that skill was putting in an IV on Earth 9 months prior, your patient is probably going to look like a pincushion by the time you practice that on Mars. So how do you practice that skill in space? You'll see design considerations. So for those of you who are more on the hardware design side, you'll see the risk of inadequate human-computer interactions, poor interfacing between the ship, the computer, and the human. So it's a very interesting list. So this is the Human Research Roadmap. The link is included there for you. So the summary from the second part of the talk is simply that there's a lot to think about in space. Space is hard, space is expensive, and as we've talked about, space is trying to kill us. So this next part is going to talk about retiring risks. So let's follow up with another question. What does the International Space Station, a remote village in Kenya, an underwater research laboratory like the Aquarius Reef Base, and a remote polar medical deployment in Antarctica or the Arctic, what do they all have in common? And the answer is they all reflect different aspects of spaceflight. Maybe they're remote, maybe they're resource limited, maybe they're isolated and confined, maybe they're all of the above. Maybe they require very, very close crew interactions in a tight space, and crew dynamics are essential. So what can we learn from these extreme environments that are analogous to spaceflight on Earth, and how can we use them to help us prepare for spaceflight? And so we call these types of environments analog environments because they're analogous to spaceflight. So let's talk about reflecting, micro, partial, and hypergravity. So how do we test in zero-G conditions on Earth without leaving the Earth? So that's through parabolic flight. So you may have heard of this called as the vomit comet. And it's simply like going over a roller coaster. So just when you're going over a roller coaster in an amusement park and you reach the crest of the roller coaster and you feel your stomach lift into your throat for a second, it's because you're weightless. You're falling at the same rate as the roller coaster for a brief second. And it's the same thing when you're going down on an elevator, that you have that same sensation. You're briefly falling at the same rate as the elevator. And so when we do parabolic flight, you're actually flying not that high. We fly about 17 to 19,000 feet. A transatlantic flight, for comparison, flies about 39,000 to 40,000 feet. And you're simply flying in a parabola. So you're accelerating upwards, and then you're falling at the same rate as the plane for a period of 20 seconds. And that gives you time to study key technologies and science. And so we've done this with the International Institute for Astronautical Sciences since 2015, minus being on hold for COVID. And here's what that looks like. Hopefully this will load. Give it a second here. I think actually YouTube might be blocked on my clinic network. So the link is there. Oh, no, I lied. There you go. Type in the chat the sound is coming from.
Power all the tasks so that I can record it. Okay.
Yeah, a very,
I would say that
that's some of the footage of what we do in flight, how you'll notice that we work very, very tightly in teams. We all know what the other person's going to do at any given time. There's a lot of human performance associated with that. And as you can see, during that period of microgravity, we are able to test critical aspects of the suit, like range of motion, maneuverability, fine range of motion, how it works pressurized with the visor down. It's a lot of fun, and it's really great for building those team dynamics and advancing what we call the technology readiness levels of key technologies we'd like to fly in space. We don't simply say that, hey, we want to fly something in space. There's actually 9 TRLs, and it goes from concept to breadboard testing to testing a laboratory environment, to testing a space-like environment, to validating it, and finally saying it has space-flight heritage. Okay, so let's get back to the slideshow here. So that's just one example of a partial gravity environment, but you might be saying, hey, 20 seconds, there's some science that we might want to test that goes beyond 20 seconds. And so other ways we can replicate altered gravity environments is through gravity offset harnesses. This is some testing that we did in conjunction with IIAS, as well as the commercial spacesuit provider. So in both cases, in the last slide, that was an intravehicular activity spacesuit. So spacesuit you would use to protect yourself inside the spacecraft. This is an EVA, or extravehicular activity spacesuit, that you would see astronauts use on moonwalks or spacewalks because it has added radiation and thermal protection. So this was in conjunction with that company called Final Frontier Design, with the Canadian Space Agency in their Lunar High Bay, as well as the University of Maryland, who had built this harness. And so what it does is it allows us to offset however much we want of our weight. So in this case, we've offset 99% of my weight, allowing me to replicate microgravity or simulate microgravity conditions like we would experience outside the International Space Station. And I'm simulating fixing a panel and hoses and connectors outside the station. Now, it's readily apparent that there's also limitations to this, because the gravity offset is limited to whatever's in the harness. So the weight of those cables still are in 1G. If I drop them, they still will fall. So there's always trade-offs into the analog test bed that you are using to validate a technology. We mentioned in one of the first slides that it's not just microgravity and partial gravity, but it's also hypergravity. So the acceleration and deceleration of launch and landing can be up to 9G, depending on the trajectory and the capsule that you are using. So we use things like centrifuge studies to study human physiology in those states. So this is at the NASTAR Centrifuge Center outside of Philadelphia. We were test subjects in the University of Texas Medical Branch's study to see how human physiology adapted to suborbital launch vehicles. And so in the utmost, in the front to back, so remember, you're always experiencing G loads in 3 different axes, up, down, front, back, side to side. And some of those are more uncomfortable than others. The amount of up, down G-force you can can withstand is a lot less than you can experience side to side or front to back. So beyond 3 Gs if you have no lower body negative pressure garment, if you're not working to increase venous return to your organs in your brain, your risk of passing out it becomes higher. And then in the max G load that we experienced in the front to back direction was 6 Gs, which again, you have to learn to breathe against that in a very there's different techniques you can use, but it feels like an elephant sitting on your chest. At one point I was, my experience was, I think I'm just going to pass out and wake up when it's over. But luckily, they're monitoring you and saying, hey, you should probably take a breath now. But that's the value of centrifuge studies. We also prepare ourselves for space through water analogs. So this is an example of testing that we've done with survival systems in Connecticut. And basically, we have an Orion capsule mock-up. So that's that vehicle that you see over my right shoulder there. That's what the return vehicle will be for the Artemis missions. And basically, we want to see how the fidelity of this IVA spacesuit checks out when we expose it to the water. So in this particular scenario, we had to egress into the water, pull the seals on our suits, pull our personal flotation devices, swim over to the raft you see over my left shoulder, climb up the rope ladder, and then be able to complete that simulation. And then we also repeated that coming off parachute harnesses. And we learned some really important design considerations about how littler and slighter body habitus, like women, no matter how hard you pull the suit seals, will, if you have a slight bone structure compared to the average size male, the water will enter the suit and make your task a lot harder. So there were a lot of key lessons learned. We learn a lot by living and working underwater. So these are snapshots from the 2019 Neptune Aquanaut mission that I took part in. And so, like I said, everything in space and exploration is a acronym. Neptune stands for Nautical Experiments in Physiology, Technology, and Underwater Exploration. As a crew of 5, we performed physiological, psychological, studies as well as technology demonstrations in those 5 days. We were at 20 feet of depth. So for those of you who are divers, you know that's not much. It's essentially surface pressure. And we were able to test key technologies that we might want to test on long duration space missions. So here, I think I talked a little bit about this last time, and the value of having a portable radiology reading room in virtual reality, so you don't have to dedicate the space to setting up all those monitors you would need as a radiologist. And I was able to link up with the head of radiology in Saskatoon, Canada, 4,600 kilometers away, to review the simulated trauma imaging or the trauma imaging of a simulated patient. Just down the road in the Florida Keys from the Jules Undersea Lodge where we conducted our mission is the Aquarius Reef Base, where NASA runs its NASA Extreme Environment Mission Operations missions, or NEMO missions. And it's the school bus-sized habitat where you send astronaut crews to become aquanauts for 8 to 16 days at a time. You're working on the crew dynamics. Again, you're performing technology demonstrations, your scientific studies, and you really feel like you're the fish in the fish tank. You can see all these schools of fish swimming by, looking at you curiously. And you begin to wonder who's really being observed here. And the value of a place like ARB or Aquarius is that you're now at 60 feet of depth. So once you are breathing the ambient air pressure at a certain depth for 24 hours. That's what the requirement it takes to be an aquanaut, but you're also considered to be in saturation. So now that all of those nitrogen bubbles that float around in your blood have gone into solution, you need to ascend at a slow set rate to be safe, lest those bubbles come out, lodge someplace bad, and cause an embolism. So at Aquarius Reef Base at 60 feet, that's 16 hours and 47 minutes to be able to safely ascend. So you truly are remote and isolated and have to rely on your own crew training and skills. And by comparison, on the International Space Station, by the time you hit an emergency evacuation, escape in a Soyuz capsule, and land on Earth, it can be as little as 3 to 6.5 hours before you get to definitive medical care. So you can actually get to medical care more quickly from space than you can from the Aquarius Reef Base. Speaking of building crew dynamics, you may have heard of the term of analog environments. So we have Mars analogs. This looks like Tatooine, but it's actually the Mars Desert Research Station in the Utah desert. You live, you build your own crews, you bring your crews, you're rotating there for 2 weeks at a time, you're bringing your own mission objectives, operations, and science. If you go outside, you're acting as if you're on Mars. You have to suit up. The geology is very Mars-like. It's incredible, and so you're really working on those crew dynamics as well as living in isolation and confinement. There's also lunar analogs out there. There's one in Poland called Lunaris. You don't have to build the entire mission profile. You can replicate some of the geology that they did during the Apollo missions. So this was our IIAS team on a planetary geology course in the San Francisco volcanic flats outside Flagstaff, Arizona. And this was at Cinder Lake where the Apollo astronauts did their own geologic training. And literally they put explosives in a dry lake bed and created craters to reflect that lunar landscape. And we did the same. And then we took lessons learned from the Apollo missions to modify geologic tools to be more ergonomic and usable based on lessons learned from those missions, and then we tested them out in the field. Again, you don't have to be in the middle of nowhere. Operational environments really help build the crew communication, crew resource management, and crew dynamics. So this is a snapshot from our 2017 high altitude noctilucent cloud research campaign in high level Alberta. We were crews of 3. I was the payload specialist. My job was to operate that computerized tomography instrument you see over my right shoulder to get more data of noctilucent clouds. And then there were 2 similar instruments situated 200 kilometers apart on the ground, again, to help get more 3-dimensional structure of those clouds thought to be related to climate change. And in the meantime, we're in a cockpit with the research pilot, as well as the mission specialist to make sure that we're on course and on trajectory. So there's so many inputs, and you're trying to figure out what to needs to be attended to versus what can simply be acknowledged and moved on from. And then resource limited environments. So this is a snapshot from the operational space medicine course that I run through IIAS. And basically we take non-medically trained lay folks and we introduce them to principles of wilderness medicine, where we're in the Colorado wilderness. We simply take away their resources and we teach them about principles of assessment, triage, and treatment in a resource limited setting. Also incorporating aspects of the spaceflight environment. So there is research around this. There's in fact new guidelines on safety and healthcare in analog environments. And so as we get to the last 20 minutes of the course here, let's look towards the future of spaceflight. Knowing all of these challenges, how do we go about providing the standard of care that we would on Mars as we would on Earth? And one way to do that is to look at the extreme of the problem, say, what if there were no constraints? How do we do that? That would simply be to bring another Earth with us. That way we would have the pressure, atmosphere, gravity, radiation protection, circadian rhythm that we would on Mars as we would on Earth. But because this is a technology course, what if we leverage technology to not just meet standard of care on Mars as we would on Earth, but to surpass it? And what if we used examples from science fiction to turn technologies, futuristic technologies, into reality? So what if we could overcome the decompensation that would occur on a 6 to 9 month journey to Mars by simply teleporting people to Mars or getting there faster? Or what if we said we could build a partial gravity space station like we see in Space Odyssey 2001, have a rotating space station? What if we borrow exoskeletons from Star Wars to help decompensated astronauts perform meaningful work on the red planet? What if we say that's still a lot of effort? Why don't we just send avatars to Mars? When we talk about skills deterioration, what if we could simply upload information to our brains? So the future is closer than we think. Here's a snapshot of how we're addressing skills deterioration. We talked a little bit about this last class, but one of the technologies that we've built at Luxonic, the company, the VR company that I work at, is medical educational modules for astronauts on long duration missions. So if you're the crew medical officer, 9 months between receiving your IV insertion training on Earth and then reattempting that on Mars without having practiced in between. You can practice that medical skill in VR. And we've since leveraged that technology for healthcare providers on Earth. I've shown you snapshots of some of the testing about making typical medical technologies more portable. So here's a snapshot of the virtual reality radiology reading room that we've created in Luxonic that we saw us testing underwater. Here's what that looks like. And it can also be used for remote environments on Earth. And here's a snapshot of what, we're going to go past this, of what some of our lunar VR medical module training scenarios look like, and some of the austere environment training that we've done, or the extreme environment testing that we've done. Here's zero-G testing of that. So moving on from skills training and immersive technologies for skills maintenance and for adhering to design constraints of the spaceflight environment, what about looking at human enhancement? We talked a little bit about this last time. So this is a article from the MIT Technology Review that says, well, if you're sending humans into this volatile environment that is going to be deleterious to their health, why don't you protect them through gene synthesis and genetic enhancement? And they propose genetically enhancing humans by splicing in elements of the elephant genome to make them more radiation resistant, because elephants have multiple copies of the P53 oncogene and tend not to get cancer. So their argument is, well, why not translate that oncogene editing ability into humans? Elsewhere in the world of genetic enhancement and engineering, the Rodent Research 19 experiment sent mice up to the space station, and they came back in September 2020. And basically, they took two types of mice: this wild type, non-genetically engineered mouse you see on the right, and this buff little muscular jacked up little mouse you see on the left. And there was an ACVR2 neuromuscular blockade in the genetically enhanced mouse. So they looked at ground mice and space-flown mice, and they found that the genetically enhanced mice with this ACVR2 blockade experienced less muscle mass loss and less bone density loss, and in some cases even gained muscle mass. So this is a way of protecting mice, in this case, against known hazards of spaceflight environments. So NASA is literally engineering mighty mouse. And so CRISPR and gene synthesis technologies are examples of how we can leverage emerging technologies to prepare for known challenges of human spaceflight. Borrowing elsewhere from science fiction, we can look at AI and machine learning technology. So here's an example of TARS from Interstellar and HAL from Space Odyssey 2001. And the thinking is, what if we could leverage machine learning algorithms to help the crew medical officer or physician with diagnosis? Because our job as physicians isn't to know everything. And as an individual, we can't know it all, but to optimize our patient management, diagnosis, and treatment to optimize patient care. So what if we could look at using an AI to look at a rash with a physician and saying, well, based on this history and based on this pattern, it's most likely to be this. We talked about the value of 3D printing last time in our exponential technologies session. So there is a 3D printer on station, Made in Space launched the first 3D printer in 2009. It's been used to print accessory parts. So what if we took that a step further and leverage that to build skin grafts, vascular grafts, scaffolds for surgery, for trauma, for in situ medical pathologies when you're on Mars, and the next resupply for medical supplies is at least 9 months away. We talked about bringing gravity with us. So again, the future is closer than you think. This is Orbital Assembly Corporation. This is one of the companies I advise, and they're literally working to launch the world's first artificial gravity rotating space station by the end of the decade, with a view towards advancing research and also studying how a lot of the physiological changes that we see in microgravity might be impacted or might be avoided in the altered gravity environment. So this is simple physics. Your artificial gravity is generated by the rate of rotation, and they're divided by the radius of your space station. So there's a lot more to it than that. There can be adverse effects. There can be you can still experience gravitational cross-coupling. Your inner ear can still be confused. There can still be a gravitational gradient from your head to your feet. If you want more reading, the company just put out a study on the challenges and potential physiological benefits for partial gravity habitats. And then moving on to other opportunities, leveraging emerging technologies and science fiction ideas. The European Space Agency has studied human hibernation for space travel, and they found by computer modeling a simulation wherein you had the crew going to Mars hibernating until 3 weeks before they reach the surface of the red planet, you could save on up to 1/3 of the volume of your spacecraft. And I'm sure there's some of you out there who are saying, well, why can't we just get to Mars faster? We talked about teleportation earlier. No one's working on teleportation yet, but there are concepts for faster rockets like the Casimir plasma engine getting from Earth to Mars in as little as 39 days. So a lot of these physiological effects that we talked about can be nullified with simply faster technologies. So the bottom line is, to help humans survive and thrive on Mars, we're going to have to science space out of this with a lot of space MacGyvering as well. So just to kind of get your brain juices flowing, let's talk about their next challenges in space medicine. So we talked a little bit about the value of partial gravity, but truly we need to delineate the gravity prescription. How much gravity for what period of time at what intervals will help us avoid the bone and muscle mass loss and the fluid shifts. How does the psychological profile of a crew selected for Mars need to change if we're talking about extending the mission duration from 6 to 12 months on ISS to 3 to 5 years for Mars? Do we send single gender crews? Do we send married couples only? Do we send older astronauts because they're already at risk for cancer anyways? The argument is, you're not increasing the risk as much as you would in a younger, healthier astronaut. There's studies around resilience and coping in austere environments. I've written a book chapter on the subject, but that kind of goes into selection for building crew resilience at the individual and at the crew level for surviving and thriving in resource limited, isolated, confined environment. And then while we're asking what if questions, what about bringing creature comforts with us? What about making an austere environment less austere? What about bringing a pet with us for morale? There's trade-offs there. There's going to be more resource utilization in terms of food, in terms of water consumption, in terms of waste management, in terms of life support system capabilities, but maybe the morale trade-off is worth it. And then alternate proposals through various research organizations that said, well, why don't you split the difference and build an AI or virtual reality-based pet that can help boost the morale of the crew without worrying about resource utilization. And in case you're wondering how animals fare in space, they literally have flown pigeons in 0G, and the results are exactly what you'd expect. The pigeons are confused, but actually learn to adapt quite quickly. This may not load in time. It's a very quick video. It's just for fun, but you can see what's really cool is they're very confused.
Pigeons normally keep their bodies in a horizontal axis while in flight. These 0G birds have lost their feeling for what is up or down and point in all directions, some even flying upside down.
So that link is there. And just wrapping up in the last 5 minutes here is kind of talking about additional questions in spaceflight. So we talked about selecting a crew for Mars, and we've talked about helping them become more self-sufficient, but the question is just how self-sufficient do they need to be? So there's precedent for considering this question on Earth. This is Leonid Rogozov. He was a Soviet physician on an Antarctic deployment in 1961. He felt a few days of fever and right lower quadrant pain. He thought, oh, let me walk it off, and it didn't go away. So then he thought, well, let me treat myself with some antibiotics, and the pain worsened and the fever intensified. And before long, he realized he had appendicitis, and he was the only physician on station. And his options were to either take out his own appendix or to die from a ruptured appendix. And so the snapshot of him is him taking out his own appendix. Now imagine having to do that on Mars. It's not ideal. So there's actually a great paper from 2012 by some of the flight surgeons at NASA and CSA saying, well, should we take out appendices before sending humans to Mars? Should we take out gallbladders? What else should we take out? And they look at the risks and benefits of how likely is an appendectomy to happen. If you do prophylactic surgery, what about the unintended consequences like bowel obstruction from scar tissue? And it goes on and on. And there's precedent for this on Earth. So this is a snapshot of Villa Las Estrellas. It's a Chilean settlement on King George Island on Antarctica. And the rule to live there, because you're so remote from medical care, it's about 600 to 800 miles to definitive medical care, is you need to have your appendix out if you're age 6 or older. So there is precedent on Earth in other isolated and confined environments. So the last bit of questions that I want to ask you, just to get your creative juices flowing, because you come from so many backgrounds with so many interests, is the radiation problem. How do we engineer habitats to sufficiently filter out all of that ionizing energy, high energy radiation without the presence of a magnetosphere? There are some reports that say, well, you can't. That would be the amount of material you would have to bring with you would be prohibitively expensive. So why not just use meters of regolith and live underground on Moon or Mars? We talked about the food problem, having a food that's low mass, long shelf life, tasty, that can provide the caloric and nutritional value that we need. So Astrius is one of the companies that I advise that's working on this problem. We also need to think about adapting our medical capabilities as the nature of the work that we do in space changes as well. So now our spacewalks are going to be not in zero G, but on rugged, slippery, dusty, rocky terrain. So the potential for trauma is higher. We need to look at how we build up those permanent capabilities and what models we use to inform our medical infrastructure based on lessons learned in austere environments on Earth, like military deployments, refugee camps, lessons learned from ISS, how we build up the training, the personnel, the imaging capabilities and supporting technologies that get us from crew medical officer training capabilities that exist on ISS to building up advanced life support capabilities to basic surgical capabilities to a full-on ICU. And then keeping in mind our design principles of low mass, low volume, low power, easy to use, hardy. And then we also have to ask the practical questions. So believe it or not, there are guidelines for CPR in space. This is the link to the paper from the European Society for Aerospace Medicine. And in addition to the logistics of how you would strap both your patient as well as yourself down to be able to perform chest compressions without bouncing away, there's also the ethical question of then what? Because even if you get return of spontaneous circulation or ROSC, if you have no life support capabilities, you're engaging in futility. So that's where this whole discussion of establishing advanced life support and intensive care capabilities come from. We talked a little bit about immunologic deficiency in space, and particularly relevant during COVID. And so what happens if COVID comes to the moon? How do we handle the first moondemic in 16G? Well, we need to socially distance at 36 feet. And we talked earlier about plans to have settlements on Mars. Settlements implies multi-generational procreation. So we need to talk about the space birds and the space bees and what a pregnancy in space would look like, question mark, followed by multiple question marks. I've written a book chapter on this. I won't get into the details because we're running out of time, but the bottom line is we have to consider everything from arousal to gamete production to fluids, the physics of fluid accumulation in zero G, to copulation, to embryo implantation, to development, to in utero development, to actual delivery in zero G, to post natal development in an altered gravity environment. So that's why I say the one line summary is question mark followed by 5 other question marks. And there's also ethical and legal considerations around this. So if you want to avoid a pregnancy on Mars, should you only send a single gender crew? Can you have a policy against fraternization? Can you mandate birth control? Should you only send postmenopausal female astronauts? So again, it's more than we can cover in about 90 seconds, which is why there's an entire book chapter, an entire field of study dedicated to it. And then we can also ask silly questions, like if you give birth in space, would the baby be an illegal alien? So as we wrap up here, other questions is how do we maintain the standard of care? Do we evolve from a World Health Organization to a galactic health organization, and how do we enforce that governance on other planets? Do we need to graduate doctors with a specialty in lunar medicine, Martian medicine? What will that curriculum look like? And because we're a resilient species, once we reach Mars, where do we go to next? So let's bring it back to Earth here in the last minutes that we have here. So we're increasingly democratizing access to space. We've so far limited our discussion to government space agency astronauts, but this is the age of commercial spaceflight. In 2021, both Virgin Galactic and Blue Origin sent up suborbital crews of spaceflight participants and commercial astronauts. In September of 2021, SpaceX sent up the first all-civilian crew, Inspiration 4, and they're having a follow-up mission with a different crew called Polaris Dawn as early as March or April of this year. So one of our research groups and I published medical guidelines on commercial suborbital spaceflight. And there's increasing literature. Here's on what happens when you send folks who aren't rigorously screened up to space. This is from the New England Journal of Medicine called Commercial Spaceflight or Human Spaceflight in the area of civilian spaceflight. So the bottom line is, on a short flight like suborbital spaceflight, which is 11 minutes, probably not an issue. But if you're sending humans to the ISS who aren't rigorously screened for 30 days or more, then the medical reasoning becomes a little bit more complicated. And along with this is the other end of the spectrum is, as long as we're making space more accessible, let's make it more accessible for everyone. So Stephen Hawking flew 0G in 2007 or 2009 on parabolic flight. The European Space Agency just announced its first ever para-astronaut. He's an orthopedic surgeon, as well as a para-Olympian, very, very accomplished astronaut. Astro Access has just flown its second campaign of 0G researchers in parabolic flight with everything from visual disabilities to paraplegia, quadriplegia. And then the last question we need to ask is, knowing that there's commonalities between the ISS and remote and rural areas on Earth, how do we bring innovations from space that have provided benefit in that remote and resource limited environment back to our most in need areas on Earth? Nearly half of our population is rural and doesn't have the luxury of access to a tertiary care hospital. So examples of benefits from space include iodine resin filtration devices to provide clean water on the ISS. They've been used to provide clean water in remote villages in Kenya. The atmospheric scrubbers that we talked about that provide clean air on ISS have been used to provide clean air in ORs, doctors' offices, and even in the produce transport chain to increase the shelf life of vegetables. Solar powered panels have been used to provide vaccines to be refrigerated in areas without electricity. So this has been a whirlwind intro into the world of space. We had some learning objectives coming into this, and basically, hopefully we've hit them all. Hopefully you're now versed in knowing how space is trying to kill us, how we prepare for space, the design considerations when it comes to preparing for space, how we prepare for space on Earth using analog environments, the value of emerging technologies when it comes to preparing for exploration class missions and beyond, especially because this is technology in the future of medicine, and emerging challenges in space medicine when it comes to long duration spaceflight, exploration class missions, as well as commercial spaceflight. In summary, there's no shortage of challenges. This is simply a takeaway slide summarizing design principles. And it's really valuable that we have all disciplines or multiple disciplines represented here, because we need you. We need the comp sci students, we need the medical students, we need the scientists and the engineers. So there's a lot of challenges to overcome, and it starts with a single step. So I'll stick around for about 5 minutes before I have to get back to clinic for questions. And then for those of you who are interested, I hope you are, you have my email address, you have the link now, and here's a whole bunch of resources on space medicine, austere environment medicine, and links to some tutorials I've done on various topics in space medicine. So thank you for your attention, and over to you for questions. I know we're at time.
Okay, that was wonderful, and I really like the fact that it's significantly updated, so it keeps
Every
getting
time there's always,
newer
yeah,
and newer. Yeah, yeah. So that's
I have a
really,
question.
yeah.
yeah, go ahead.
Yeah, so as someone that isn't, I guess, well versed in this field, like I didn't know there were like all these missions going on and they already like they just flew for civilians.
Yeah.
So like like realistically, like in your opinion, like how far do you think down the line will like space travel be like accessible to, you know, someone like me, like because it seems like it's way faster than what I actually had in mind.
Yeah. So that's a great complicated question. One of the greatest takeaways, I did my master's in space studies at the International Space University, and that was a crash course into everything related to space, from rocketry to economics and policy to space medicine. And one of the most important takeaways is the order of how things happen, whether it's transportation or space flight, is political will, economics, and then technology. The technology part is actually the easy part to overcome. It's having the policy and infrastructure that will protect this. So suborbital spaceflight has been in the making for the past 2 decades. Virgin Galactic thought they would fly passengers as early as 2009. They were running experiments in the Mojave Desert in 2004, but delay after delay, global recession, having tragic crashes where pilots lost their lives set things back. So 2021 was supposed to happen a decade earlier. And so we're cautiously optimistic that we are at the inflection point. This has only been happening since July 2021, despite the global pandemic. So we're now on this upward trajectory, and it depends on if these commercial companies can keep going. Virgin just had a huge setback when one of their payloads failed. Their first UK launch failed to reach orbit last week. It tanked their stock, so they're in trouble. Blue Origin's New Shepard 23 flight failed to reach orbit. It was not crewed. It was just a non-human intended payload. No one was on board. Failed to reach orbit in August. So now there's an FAA investigation. So we're cautiously optimistic. So then this is where hopefully we can get to future projections next workshop. We're gonna have to fit a lot into it, is what is the best case scenario versus the worst case scenario versus the most likely case scenario. So in the current trajectory, we may still get to where we can bring down the price of access to space in the next 10, 15 years. But if we have continued aborts and suboptimal launches, these companies might go out of business despite having the backing of billionaires like Branson and Bezos. So it's a very, very nuanced question. But the one takeaway is when you're looking at any new technology and change, it starts with policy and political will and the backing, the financial, economic backing, and then the technology.
So any other questions? Okay, well, that was an absolutely great teaching session, and I've copied your link to the slides, and I'll send it to all the students. So
Thank you.
And we're really looking forward to Thursday, and I want to re-emphasize that you can bring extra people. So
the more the better, the merrier. The better, the merrier.
Yeah. And some of the coolest videos from the past have a lot of medical students there who had no idea what the class really was, but were so fascinated by what was going on. Was part of the sort of intrigue is the starry-eyed medical students who were trying to figure out what alternative reality they had ended up in. Yeah. So anyway, we'll see you all on Thursday face to face, and I think that will be a very memorable session. Okay.
Looking
Thanks.
forward. Take care, everyone. Bye.
Bye-bye.